Now, hot on the heels of price-fixing investigations in the construction sector in South Africa, announcement that there will be an investigation into the private healthcare sector as well. So joining us for more on that are Daryl Dingley, who's partner for competition practice at Webber Wentzel, and Alex van den Heever, who's an independent health economist. Daryl, perhaps start with you, and it's well-timed this because Mediclinic happened to report this morning. We had Netcare last week. Now, these hospital groups have done well. They continue to grow well, and as I said, it's a grudge purchase. You'd rather not go to hospital, but if you are, their business is growing. And one just imagines people in the Competition Commission and elsewhere saying these profits are too high. In fact, they need to be investigated.
Yes, I mean, and the terms of reference, in fact, specifies that profitability is one of the issues that they'll be looking at. So it's one of the issues. Of course, there are other issues that they're also looking at in relation to hospitals, as well as in relation to funders, and also in respect of the service providers. What's
your sense? Is there a lack of competition, or is there not enough competition in that sector?
I think that there's a number of features. I think that it's a very complex market. It's obviously regulated, as well as there's also free market principles that apply. And I think that the inquiry shouldn't focus just on one sector. It obviously needs to focus on everything. And I think one of the criticisms of the terms of reference is that it should be broader. I mean, it certainly should, for example, look at the public sector as well, because we all know that there are private-public partnerships. The state, decisions of the state impact upon the private sector. So, for example, nursing salaries, that has a major impact on the private hospitals, for example. So there's a lot of elements that need to be looked at. I also believe that in respect of funders and administrators, the terms of reference doesn't look at the profitability of that sector. Profitability of the administrators doesn't look at consolidation in that sector. So I think there are a number of issues that could be incorporated in these terms of reference.
So, Alex, a lot of fine-tuning that still needs to happen here. I mean, how much room do you see there being to maneuver? Because we've had various stakeholders having raised concerns about pricing, costs, the state of competition, innovation within the private healthcare space as well. And, you know, we've had a hospital group come to the fore saying that what it would mean if they are forced to put a squeeze on prices or bring prices lower is that we're going to see lower quality of healthcare services being provided. So therein lies a risk.
Well, I don't agree. I think firstly the market inquiry itself is required to deal with primarily structural issues of competition within the system, which means that it isn't a focus on, you know, high profits being made this year, and therefore there is a sudden focus. This is something that's been a long time coming. There have been a large number of hospital-based mergers which have raised many issues, and although the tribunal has approved a lot of those mergers, the question as to whether the merger process is the best way to handle them has been raised. There are so many relationships throughout the industry which affect structure and efficiency that one does want to basically look at how one unlocks efficiency in a market that's operating now. And I would say that at the moment, if you make the market work better, the consequence is actually lower cost and better efficiency, better quality of care. There isn't a trade-off necessarily at all.
Alex, aren't there some built-in competition drivers? In other words, the medical aids, the pharmaceuticals and the hospital groups, in their relationship with each other, they obviously have an interest in having one of the other players have lower prices.
Well, the problem with medical scheme competition is that they can reduce their costs in two ways. They can either negotiate better arrangements with providers, or they can just cut benefits. And the problem is that most medical schemes default onto that option.
The second option, cutting benefits.
Cutting benefits rather than actually creating competition amongst providers. I would argue that South Africa's hospital groups compete less than the public hospitals and the National Health Service in the UK, where they've introduced an internal market mechanism to make them compete. Our private hospitals do not compete. Our specialists do not compete. Our service providers do not compete at all, despite being in a private market. And it is a result and a consequence of the impact of an insurance-based system on a group of sellers, basically, of services. And there are lots of conflicts of interest within that system. I think that within medical schemes they might have been competing up until now, but I think that within about 3 to 4 years we're going to be sitting with an oligopoly market on the funder side, And there is also an issue about how administrators compete in the system separate, independently of medical schemes. They themselves do not compete in every instance efficiently, and sometimes their business is entirely reliant on the relationship they have with the board of trustees of a particular scheme. And therefore they don't have to compete for business, and they can have very, very high profits just because they're never under threat of losing their contract.
So Daryl, where this is the situation that we face right now, I mean, what do you anticipate the result of this inquiry being? Are we going to see the effective dropping of prices within this segment of the economy?
Well, the Commission has to come up with a report, which is then presented to the Minister. In that report, they'll have, it might include recommendations, that could be policy recommendations as well as amendments to legislation. I think that they could also obviously initiate complaints, for example, and refer matters for prosecution if they come across evidence that there's excessive pricing, for example. But some of those recommendations might be increased regulation of the sector, and that's what I think a lot of people are talking about. Well, will they decide to actually impose tariffs, for example, on service providers to keep costs down? And that's one of the things that we're obviously looking at quite closely.
Isn't one of the players or groups of players is the specialists? You refer to specialists, doctors. It's a little bit like advocates in the law. They're individuals. They charge what they want. I'm not sure how that market operates, but how do you control what individual specialists do?
Well, one of the problems with specialists is that the consumer that they deal with, just referring to them as consumers, are price insensitive when they meet with them because they're insured. So within such a context where a specialist basically doesn't have to compete on quality, and also all of their information on quality of care is opaque. There is no real information on whether one specialist is better than another.
How many of your patients have died? We don't have this information.
And it's not out there systematically. So the issue is that some of the fundamental requirements for a normal market to work are missing. And you can't just have people setting their prices in an insured market like this. You have to reintroduce a balance between, you have to connect them back to the budget constraints. And the budget constraints are not at the individual household level, which it would be if you're buying Coca-Cola or buying a product directly. When it's being purchased indirectly through a medical scheme, it essentially, that's the budget constraint. But the person who's actually making the decision to buy is price insensitive. Under those circumstances, you've got a number of fundamental problems with the market which need to be corrected structurally. They're not about chasing up bad apples within the system, of which there are many on all sides, all the way through the system. Essentially, you could pick your area and find a bunch of people and prosecute them at the end of the day. I don't think that's very helpful. I think that what would be much more useful, and I think that's really the purpose of the market inquiry, is to look at those critical structural elements that need to change, not extra regulation, but better structural frameworks in place so that you can, for instance, remove the asymmetries of information within the system, remove the problems with information, make sure that the people who are actually buying do buy with some effectiveness.
Where this requires then a structural shift. I mean, Daryl, where do we draw lessons from so that we start getting this more right than wrong?
Well, I think one of the interesting things about the inquiry is that they are going to do a sort of retrospective analysis. So they are going to look at past matters. So when they approve these mergers that Alex was talking about earlier, they're going to look at, well, why did they approve these mergers to allow the increased concentration in the hospital sector? They're also going to look at their interventions in the past when they intervened, for example, in the national reference price listing debacle, and see what lessons can be learned by those interventions, and hopefully that will inform their interventions going forward.